Good morning. Welcome to this webinar that is organized by the World Bank Institute together with the Health, Nutrition and Population Global Practice of the World Bank. Today's webinar will focus on universal health coverage and the challenge of informal employment. This was the title of a document that was produced in the context of a bigger program on the health and economy. The objective of this program was to build a framework for exploring the links between health and economic development. And so informal sectors are often left out of health insurance mechanisms in countries, which has a negative impact on economic development. Our presenter today is Ricardo Bitran. He worked on this paper, he wrote it, and he is a senior health economist from Chile. He has worked over 30 years as a policy advisor, researcher, and professor in Chile and the US, and he has experience in over 40 developing countries. So without further ado, and for the sake of time, I will hand over this presentation now to Ricardo, and I'm very excited to have him here and to listen to the important results that they achieved with this study. Over to you, Ricardo.
Thank you so much. I have yet to see my presentation on the screen. Thank you, Joe. Good morning, everyone. The title of my talk is Health Insurance for the Informally Employed, Lessons from Developing Countries. The research objective is as follows. In light of the current drive to achieve universal health coverage, I was asked to review the experience of developing countries with health insurance coverage extension for informal sector workers. I was also asked to identify some challenges that countries have faced, to draw policy lessons, and to propose an agenda for further research. Those of you who would like to see the full detail of my research are welcome to download the paper that I wrote that's available for free on the web. That's the title of the paper. How did I do this research? I carried out a review of the published literature. There's not a lot of literature on the subject, but there is some, and some of it is dated. I also did a review of the great literature which touched upon the issue of coverage with health insurance for informal sector workers. And in addition to that, I conducted interviews of key health policy informants from a sample of developing countries in Latin America, in Asia, and in Sub-Saharan Africa. Then I added some more countries to the study, including China, Indonesia, Mexico, and several others. The phenomenon of informal employment is characterized as the labor markets of developing countries. What you can see in this figure is per capita GDP of countries in the horizontal axis, and you can see in the vertical axis the share of the working population that's in the informal sector, not including agricultural sector workers, most of whom are informal. And what you can see is that in most of these developing and transition countries that are shown on the screen, informal employment is 50% or more. And in poorer countries, informal employment is even higher. I'm not showing it on this slide, but informal sector workers have been growing as a share of total employment in developing countries over the past 2 decades, with the exception of sub-Saharan Africa. So the total number of people who are in the informal sector is going up in most developing and in many transition countries, and therefore the challenge of dealing with health coverage for this population is getting a bigger challenge, and it's a very important one from a public policy standpoint. Let's consider the perspective of an individual who is in the informal sector and who's thinking about joining health insurance. So if the individual wishes to join health insurance, he or she has to pay a premium, and this may give them the access to the possibility of having better access to health care and to face smaller out-of-pocket payments. The other option is to actually to remain uninsured, in which case accessibility to quality healthcare may not be as good, and out-of-pocket payments for healthcare may be higher than if you're insured. So the informal sector worker looks at these two scenarios, having or not having health insurance, makes a decision. And the variables that influence this decision are age, gender, current health status, expected health status, income, education, the amount of the premium for health insurance, the difference in access that people have if they're insured versus uninsured, and likewise, the difference in out-of-pocket spending if they're uninsured versus if they're insured. Let's look at the problem of offering health insurance from the government's perspective for informal sector workers. So government may choose to enroll informal sector workers in health insurance, but this is going to have a fiscal impact. There are important financial costs for government of enrolling people in health insurance. There are enrollment and administrative costs, and more importantly, there are the costs of the health services that government might co-finance for informal sector workers. But if government provides health insurance for informal sector workers and provides some subsidy for it, there will be social benefits, more equity in the country, better health status, more financial protection, and greater consumer satisfaction. Or government may choose not to deal with the problem of offering health insurance for informal sector workers. That may have a lower cost for government, but it's going to have lower social benefits, less equity, less health status, less financial protection, and less satisfaction of the population. So government has to ponder these two scenarios and make a decision about whether or not to cover informal sector workers and how to cover them. And this decision depends on the expected net costs, the cost of enrollment, the cost of health services, and the expected net social benefits in terms of improved equity, health status, financial protection, and citizen satisfaction. Now, in most of the developing countries, the health system is segmented. There's one health system for the poor and vulnerable on the left of the screen. Then there's another health system for the non-poor informal sector. And there's another segment for the non-poor formal sector workers. And when trying to provide or deal with the problem of health insurance coverage for the informal sector, the ones that are in the middle shown in pink, there are a number of problems that arise. The first one is adverse selection. Often, if government offers health insurance for informal sector workers and enrollment is voluntary, it is those who have worse health status that are going to be more likely to enroll. That's called adverse selection. Also, government may want to collect a premium to informal sector workers who enroll, but collecting this premium may have high administrative costs, and it's difficult to collect a premium because informal sector workers do not have a work contract, and it is therefore difficult to figure out how to collect from them. Another problem is that if enrollment by informal sector workers is voluntary, typically there is low enrollment. A large share of informal sector workers decide not to enroll. There are also incentives in the system for the non-poor informal sector workers to misrepresent their income and to pretend that they're poor so that they will get fully subsidized government health care. And there's also another perverse incentive, but this one is for the non-poor formal sector workers who may be tempted to actually switch out of formal employment into informal employment in order to get some subsidy in exchange for a benefits package. So these are all the problems that governments face when dealing with policies to provide health insurance for informal sector workers. So some of the important policy questions are, what should be the benefits package for the informal sector, and what should be the premium charged to the informal sector so that they can get health insurance, and what part of the cost of health insurance for these segments should come from premiums, what part should come from a government subsidy. Let's look at some country cases or cases coming from regions, and I want to begin talking about community-based health insurance. There are many initiatives of the sort of community-based health insurance in Africa and Asia, and these initiatives that have often been decentralized, many of which have been supported by donors, they have improved accessibility and financial protection for the individuals who have joined community-based health insurance. Typically, these schemes function in the rural area, though there are some in urban areas as well. But scaling up of community-based health insurance has been slow, and population coverage remains low overall, with the exception of Rwanda and Ghana. In most community-based health insurance, enrollment has been voluntary, and this has led to adverse selection. And overall, I concluded in my paper that community-based health insurance has not been an effective solution to the problem of offering health insurance for informal sector workers. Let's move on now and talk about the case of China. China is moving or is almost at the brink of achieving universal health coverage. And the Chinese health system has 3 separate health insurance schemes. There's evidence that the current system has improved accessibility. It also has led to some improvements in health status, but there's no evidence yet that this new system in China has improved financial protection. There remain issues about financial protection in China. So the first system is called the New Rural Cooperative Medical Scheme for rural residents. The second system that's in pink right in the middle is a system that was devised specifically to provide health insurance for informal sector urban workers. There's a small mistake here at the bottom. It should say informal sector urban workers. And then there's a third scheme that's called the Urban Employee Basic Medical Insurance that was devised for formal sector urban workers. The table that I'm showing you on this next slide shows the 3 schemes, each of them at 2 points in time, the year 2010 and the year 2008. What we can observe from this table, and I'll try to facilitate your reading of the table first, is that there's very high enrollment. All 3 schemes have achieved over 90% enrollment by the year 2010. So China in 2010 was nearing universal health coverage. Second, there were different premiums for these different schemes. Formal sector urban workers pay a premium that's about 10 times as high as the premium that's required of informal sector urban workers and also of rural residents. So there are premium differences that are significant. Also, there are significant government subsidies for informal sector workers and for rural residents, and no government subsidies for formal sector workers. And fourthly, there are important differences in benefits. There's a much more generous benefits package for the formal sector urban workers, and there is a smaller, more modest package for informal sector workers and for rural residents. And probably these differences in premium and in benefit packages and in government subsidies are responsible for the success of the Chinese efforts to provide health insurance coverage for everyone, including informal sector workers. Let's talk about Brazil now. Brazil is an interesting case. Like most countries in Latin America, in the 80s, Brazil relied on social health insurance to provide health and pension benefits to the population. At the time, 40% of the population was informal sector, and Brazil decided that it wanted to switch and abandon social health insurance and move to a different model, that's the national health system. And that was kind of a drastic way in which Brazil sought to deal with the equity problems in its health sector, but just by making a significant switch in the system and by trying to have a new system where all citizens have access to the same benefits that are mostly subsidized by government. There is not a lot of evidence about what has been the impact of Brazil's reform, but there is evidence, and I will not get into it because it's too much and it's beyond the scope of this assignment. But the main point is that Brazil made a drastic change partly to deal with the segmented health system that it had. Let's move on and talk about the Dominican Republic now. Informal sector workers in the Dominican Republic represent 57% of the labor force. That's a very high percentage. In 2001, government passed a new legislation creating 3 segments in the health system. First, for formal sector workers, it created what it called the contributory regime. It's shown on the right-hand side of the figure. For the informal sector workers, it created a contributory subsidized regime that's shown in the middle in pink. And for the poor, it created a subsidized regime. The idea was that the poor would get a full subsidy from government and get healthcare free of charge. The non-poor formal workers would fully finance with contributions their benefits. And in the middle was left the informal sector workers, who, as I said, represent about half of the country's population. The idea was that informal sector workers were going to provide some premium and government was going to finance the rest. What happened in the Dominican Republic? Well, let me make the end of the story short. It did not work. Informal sector workers have been reluctant to enroll. Many of them who are poor or semi-poor or vulnerable, they are actually already enrolled in the subsidized regime. What government wants to do is that they want to discontinue this special regime for informal sector workers. Government is considering offering them some subsidies so that everybody is going to be either in the subsidized regime or will actually move to the contributory regime. but it remains to be seen what the Dominican Republic will do. What is clear is that they have not been successful in covering with health insurance informal sector workers. Let's talk about Chile now. This is an upper middle income country with 1/3 of the labor force who are informal sector workers. Chile has a two-tiered health system with a very large public insurer that covers 80% of the population, and with private for-profit insurers that cover about 17% of the upper income of the population. To enroll in social health insurance, people have to pay 7% of their declared salary or income, either to the public health insurer or to private insurers. The indigent can get free coverage from the public insurer without making any contribution of any sort. So in this slide, I'm showing you the big public insurer that covers 80% of the country, and then the private insurers that cover 17% of the country. Now, a reform that was passed in 2005 set up a benefits package that covers healthcare for 80 priority diseases. Everybody in the country has access to coverage for these 80 priority diseases. Now, people who are in the informal sector, the majority of them have enrolled with the public health insurer, and they contribute 7% of their declared income to the public insurer. Now, Chile has been successful in enrolling informal sector workers into social health insurance. However, the system has not been free of problems. One of the problems is that there's a fair amount of fraud. Many people who are in the informal sector and who are not poor pretend to be poor and trying to join the public insurer in order to get the free benefit package. Government has been implementing different measures to try to reduce this amount of fraud. Government has also been implementing some measures to keep high-income individuals to obtaining free health care from government healthcare providers. Overall, Chile's experience in enrolling informal sector workers has been successful, but government has to subsidize about 1/2 of the cost of their health insurance. That has a big fiscal impact. Let's talk about Colombia now. In 1994, Colombia passed a major health reform which set up two regimes in Colombia's social health insurance system. A contributory regime for the non-poor and a subsidized regime for the poor. Initially, and up until today, these two systems offer different benefit packages. For the poor, there was a small benefit package, and for the non-poor, there was a large benefit package. It was the idea of government that by the year 2000, both benefits packages would be the same, but that didn't happen because government didn't have enough resources. So one of the problems that Colombia faced was that informal sector workers did not want to contribute to the contributory regime. They tried to enroll in the subsidized regime by passing us poor in order to capture the government subsidy, but government set up a system to try and control fraud. It was a beneficiary identification system which worked reasonably well, but still formal sector workers were not enrolling in large enough numbers. Now, the new government of Colombia has decided that it is time for the benefit package of the poor to become the same in contents as the benefit package of the non-poor. How the government is going to finance this expansion in benefits and what consequences this is going to have on health insurance for informal sector workers remains to be seen. Now let's talk about Vietnam. Informality is very high in Vietnam. 75% of Vietnam's 46 million workers are in the informal sector. In 2008, Vietnam passed a health insurance law which mandates enrollments for all citizens with Vietnam's social security system. The law envisioned that farmers would have social health insurance coverage by 2010, and then everybody else, including informal sector workers who are outside of the agricultural sector, would all be enrolled by the year 2014. But that actually has not happened, and to date, about over coverage in Vietnam's system is nearing 60%, if I'm not mistaken, but a large share of informal sector workers still remain uncovered. They have been 40% of informal sector workers have been unwilling to enroll in social health insurance. One of the reasons that they don't want to enroll is because they find that the premium is too high for them. They also don't want to enroll because they perceive the quality in government healthcare providers to be low, and also because there are informal co-payments in government health facilities. So if an informal sector worker enrolls and pays a premium, he or she is going to face informal co-payments in government health facilities, and these may be significant, so the insurance coverage is going to be limited. Now, let's move on to Ghana in Africa. Ghana has been carried out a remarkable health insurance reform, considering that it's a low or middle income country in sub-Saharan Africa. It set up a fairly sophisticated national health insurance system with the aim of achieving universal health coverage. I'm not going to get into the details of Ghana's national health insurance system, but I've been working with them recently, and one of their major problems is that only a small fraction of informal sector workers have joined the national health insurance system. Even if they're asked to pay a premium that's smaller than their cost of care, informal sector workers, for the most part, do not want to enroll. So this is my last slide. I want to present my conclusions. No country has come up with an effective way of covering informal sector workers while at the same time collecting significant contributions from them. Many countries have set out to cover informal sector workers in the hope of collecting a significant premium from informal sector workers, but that hasn't worked. Large amounts of public subsidies are required to enroll informal sector workers in health insurance. A solution that some countries have adopted that seems to work is to offer smaller benefit packages for informal sector workers than for the formal sector workers. Otherwise, people in the formal sector may have incentives to switch to the informal sector. Also, if the package of services for the informal sector workers were too large, government would not be able to pay for it, and we know the government has to subsidize a big chunk of it. The benefit package for the poor is often smaller than for informal sector workers, in order to prevent informal sector workers from attempting to pass as poor in order to capture the government subsidy. For these systems to work, there's a need for strong beneficiary identification systems. There's also a need for systems to keep the non-poor from getting free healthcare from public facilities. Some countries have resorted to a method that has been very effective, which links health contributions to other social contributions, such as contributions to pension systems. And this has been an effective way of reducing evasion and elusion by informal sector workers. The objective of covering informal sector workers with a large benefit package that's the same for everyone in the country will probably take decades, and vast amount of money, public subsidies, are going to be required to cover them. And governments not only should be aware that benefits for informal sector workers may have to be limited, but also governments should not expect to collect much in the form of informal sector workers' contributions to the health sector. That's the end of my presentation. I've been talking for nearly 30 minutes. I'm going to shut up now.
Okay, thank you very much, Ricardo. That was very interesting. In order for us to process a little bit better what you presented, I would like to ask our audience of about 30 people to vote on these questions. So who is classified as an informal sector worker? And the idea is that you answer this from your own experience in your own country. So we see some results coming in, and it's all over the place in terms of numbers. And I guess that goes to that speaks a little bit to how difficult it is to define this group of people. I think we're probably almost there, so I would like to give it maybe a couple more seconds. Okay, let's move on to the next question. So the next question is, what are the causes of limited access to health services? And you can, again, select all that apply from this list, and it's what is relevant to your experience in your country. So I think we see a convergence on A and B, the relative cost of insurance for the poor and in communities with no or substandard health clinics. That seems to me to be the commonly agreed cause of this. Okay, I think we're about done with this question. Let's move to the next one. So which of the following is the best way to maintain a successful healthcare service for the informal sector workers? So I guess you can here only select one. So what do you think? It's government programs, it's community insurance, NGO clinics, universal health care with subsidies, finance health insurance with portion of all government revenues, tariffs and taxes, or all of the above. Okay, so it seems like majority of us would prefer a universal healthcare system with subsidies, or to have a budget, a government revenue finance system. So, Ricardo, I would like maybe if you could comment on these results a little bit. In view of what you found in your study?
Sure. What I found in my study is that Governments in developing countries often have tight resource constraints, and therefore they're not in a position to subsidize healthcare for everyone. So typically, health policies consist of systems in which the non-poor have their own health insurance, which they finance themselves with their own contributions. And also, the poor and the vulnerable tend to have access to free health care, which is fully subsidized by government. And in the middle remains the challenge of this large chunk of the population that's in the informal sector. Uh, and for them to have health insurance, what I have learned is that government should be ready to subsidize a big portion of their healthcare costs, and government should not expect to draw much in revenue from them. And in addition, the size of the benefits package that government should offer to this group that's in the middle should not be as large as the benefits package of those who self-finance healthcare, and it should not be as small as the benefits package of the poor. It should be somewhere in the middle.
Thank you, Ricardo. So I think we're now ready to move into a question and answer period. And so for the participants, you can pose your questions by typing them in the chat area. There's a white box on the bottom where you can type. And we will look at them, and then Ricardo will answer the ones that you posed. Okay, so there was one question that I wanted to, or one comment from Manoj Kumar. He commented that there are many non-poor individuals working in informal sectors trying to pose themselves as below poverty line to draw the many benefits of the insurance that are meant for the poor. And this refers to India. So I just wanted to, because he typed in a different section, I wanted to highlight that.
I see some questions that are being posed now. Joe, should I go ahead and try and answer them?
Please go ahead. Ricardo, you can just answer them verbally.
Sure. There's a question there on whether or not there is a different approach to occupational injuries versus general sickness and diseases, and the answer is yes in Latin America. I'm aware of the system that most Latin American countries have of a specific insurance for occupational injuries and occupational diseases. It's financed separately from social health insurance, so it's a separate regime. Then there's a question by Allah Hamed that says, why do we then separate between a system for the poor and the informal sector if both would have packages that are not much different between them and the government to subsidize both of them? Well, some countries have chosen not to make a difference between both, but governments are limited in their ability to subsidize healthcare. Now, if you add the poor plus the informal sector, that may represent up to 80% of the population. So government cannot finance services for as many people. And therefore government seeks to get some subsidies, to deliver some subsidies to the informal sector, but also to try and collect some contribution of them. And for them to contribute, then their benefits have to be somewhat higher than those of the poor. Imad El-Azazi asks, would you please give insights on your experience and research about charity and nonprofit organizations' role in quantitative initiatives? What I have seen in Latin America, in Africa, and in Asia is that nonprofit organizations and charities have not played a significant role in solving the problem of providing health insurance for informal sector workers. I think that they have played a very important role in helping with health insurance for the poor, but not as much for the informal sector. Alison Kelly says, hi Ricardo, informal sector workers are so heterogeneous, from poor to rich. Is sub-Saharan Africa, where the percentage of the informal sector is so high, one suggestion is that some of the informal sector needs to be formalized. Has that been done successfully anywhere based on your study? Well, formalizing the informal sector can be done, for example, by asking them to identify themselves and to make an explicit contribution to health insurance. And yes, that has been done in most of the countries that I described. By the mere fact that somebody comes and declares their intention to join health insurance, it means that they're being formalized, or that they're identifying themselves. Now, having it formalized by having formal work contracts and by having them a legal document by which they make contributions to pensions and to health, that has been much more difficult to achieve. Laurel Hat says, given the conclusion the benefit package might be smaller for the poor, smallest for the poor, small for informal sector workers, what are the implications for equity? Well, that is inequitable. Having different packages for different groups of the population is inequitable. But this inequity naturally comes from the fact that governments in poor countries have limited resources. So governments cannot provide as much as they would like to everyone. And because of perverse incentives that I described earlier, such as adverse selection and misreporting of socioeconomic status, it turns out that as countries evolve and their incomes get higher, it looks like having different benefit packages for different population groups may be a solution. It poses an equity problem, but it is one that cannot be fully solved because of the lack of resources. Lara Brearley is asking, if government can expand fiscal space, should there be a universal subsidized system in low or middle income countries with a large informal sector? Yes. In these countries, government have been looking for more fiscal space to provide more subsidies for low-income and middle-income informal sector workers. But oftentimes, those subsidies have been insufficient to provide adequate health insurance for these large groups of the population, which is why governments also try to get some contribution from informal sector workers. Adeola Mayagbe is asking, what did you find provided best financial protection for developing countries? Catastrophic cover versus cover for general diseases. Many countries provide both catastrophic cover and cover for general diseases at the same time. The best coverage for financial protection is catastrophic cover, that is, subsidized health care for costly health services. That is what works best. There are some countries that have separate health insurance funds for catastrophic health care, Mexico, for example, is one of them. Chile has that as well, and they have worked reasonably well, and that provides a fair amount of financial protection. Vini Aristianti, could you please kindly give us your opinion about the best way of initiating the collection of premium from the informal sector workers in a social health insurance scheme? The best way that I have seen is by having social workers in government health facilities, especially in hospitals, but also in health centers. When informal sector workers come to these health facilities to seek free health care, they are subject to a means test. And if the conclusion of the means test is that these individuals are not poor and that they are non-poor informal sector workers, then they're invited to join this informal sector workers regime of social health insurance and to make a contribution. All right, Manoj Kumar Pati. In my view, in developing countries like India, government should decrease relatively the cost of insurance for the informal sector while decreasing the range of services. But the major challenges for the administrators are how to identify these people and categorize them into a single group. There's always a transition going on between informal sector workers and formal sector workers in countries like India. How to deal with that situation? That is a major challenge. India has recently decided to have, India is a country which relied very strongly on out-of-pocket health financing. About 80% of resources in India for healthcare came from out-of-pocket payments. India has been moving very aggressively implementing government subsidized health insurance, and one of the risks of these government subsidized health insurance is that many people who are non-poor are actually will want to join government subsidized health insurance, and given that resources are limited, there may be many people who are not poor who will try and join these government subsidized schemes, and that's going to be quite a challenge because government subsidies are limited. Wow, there are many questions here. Let me see if I can move on to the next. Ralph Radermacher. I wish to comment on two topics. A, the right insurance setup, including identification mechanisms leading to reasonable administrative costs. In my experience, a number of schemes aiming at large-scale coverage suffer from some design issues.
Ricardo, can I interrupt you for a minute? I think
Please.
Ralph just made some comments that everybody can read. It's not in the interest of time. Maybe we should move to Lara's question. It's not really a
Okay.
question. He gives some very interesting things about Tanzania, but everybody can read this. So let's move on to Lara.
Okay, Lara asks how to balance the social cost to equity and right versus the fiscal cost of equalizing benefit packages. This is inherently political as it's possible the public sector could subsidize a smaller package for all, but the more advantaged are unwilling to give up benefits. Yes, I think, Lara, that you've phrased the dilemma very nicely, and that is precisely what Colombia is currently facing. The government there has decided that they want to give the same benefit package for everyone, irrespective of their income or health status. But it remains to be seen if Colombia's government is going to be able to come up with the enough resources to achieve what it wants to achieve for the sake of equity. I myself remain quite, what's the word, unclear that government is going to achieve its objective. Ralph, okay, then there's Uzaib Saya. Hello, did you find that informal sector workers may use other sources of financing, such as various saving mechanisms to pay for catastrophic health expenses? Is there a way we can better understand their ability to save and pay for unanticipated expenses such as these? No, there is not much evidence that informal sector workers are saving in anticipation of future healthcare costs. I haven't seen many studies of this. There are countries that have health savings accounts, but these are organized health savings account systems, mostly for formal sector workers. There is literature about mechanisms that community use to help community members pay for high healthcare costs, but these are not initiatives that allow countries to deal effectively and systematically with the major problem of providing equitably health insurance for informal sector workers. These are social attitudes, community responses to social problems such as paying for costly health care, but they are not able to solve the national problem of a large informal sector.
Okay, well, I think this has been a really interesting discussion, and I would like to move on to close the webinar. Ricardo, do you want to say some final words to kind of tie it all together and some parting wisdoms?
Yes, I'd like, thank you, Joe. I think that those countries that are facing the problem of a large informal sector that does not have adequate access to healthcare often fall in the mistake of promising a large set of benefits that are going to be subsidized by government. And that often cannot be achieved because governments have tight resource constraints. Also, many countries make the mistake of assuming that they're going to be able to collect lots of premiums from informal sector workers and that these premiums are going to pay for the healthcare costs of that group of the population. That hasn't happened anywhere. Few people from the informal sector join. Those who join unpaid tend to be those who are very sick, and therefore the system becomes costly, and the amount that they pay tends to always be less than the actual cost of services, so government subsidies are necessary. Governments should not make false promises to informal sector workers.
Thank you, Ricardo, for, as I said, for a very interesting seminar, and I think many of the participants agree with me, judging by the comments that are being typed right now. So, as I said before in the chat, all resources, including the video PowerPoints, can be found tomorrow on the E-Institute website. You can see the link on your left-hand side of your screen. If you just go to einstituteworldbank.org/webinar, you will /EI/webinar, you will see a list of webinars, and you can choose the one, so you don't have to type that entire long URL. And you will see a long list of webinars that we organize there as well, so there might be some topics that are of interest to you. Also, to let you know that we will be doing a series of webinars on these topics of health and the economy, starting probably in August, and so keep an eye out on this this webpage, the einstituteworldbank.org/EI/webinar, for announcements on when these webinars are going to take place. Now, the last thing that I would like you to ask you to do is to fill out a very short evaluation form, so that we can keep improving these webinars. I thank you all for your attendance, and it was a really interesting experience. So thank you very much for attending, and please fill out the evaluation form. Thank you. Bye-bye.